Now, of course, we have more questions to go, so let's throw another 2 minutes up on the clock. Your time starts now. So Amelia Kowalski is a 38-year-old female photographer who attends your GP clinic complaining of a 1-week history of facial pain and nasal blockage. Her symptoms began with a recent change in weather. She states she often gets this at a particular time of year. She has no other significant medical history and takes no regular medications. She is a non-smoker, but her boyfriend who she lives with smokes 10 cigarettes a day. She doesn't drink alcohol and denies any recreational drugs. COVID has been definitively excluded. Her heart rate is 67, blood pressure 121 on 81, her respiratory rate is 14, and her BMI is 25.7. What aspects of history would indicate a serious cause of her symptoms? List 4 additional aspects of history. All right, so let's have a look here. Now, this is a question that in particular is worth paying attention to because they specify things like boyfriend she lives with smokes 10 cigarettes per day. That's always something I think it's worth filing in the back of your mind because there is so little space and time in this exam to put down information. And so you have to presume usually every detail they give you is noteworthy in some way, shape or form. Pardon me. So let's have a look through some of my answers again. You probably noticed I would go through and write down 1, 2, 3, 4, making sure I'm answering the exact number of questions that are being asked. So we've got a couple of awesome things in here. So severe headache, fantastic, as well as fever, weight loss, very good. Now, acute onset of confusion or impaired consciousness is an absolutely extreme example for something in this kind of a setting, but would be something that would have you considering a more sinister cause, and that would be, of course, if the infection had actually turned deeper and was turning into more of a meningitic type picture. Likewise, diplopia or impaired vision can be early markers. Other signs of meningism such as neck stiffness, severe headache or photophobia. Periorbital edema or cellulitis, again acknowledging that we've got those symptoms there of the facial pain and full sensation. Could this actually be an ocular presentation? Proptosis, again, going down eye presentation. Epistaxis, being that migration through the nasal passage into deeper tissues. Persisting fever of 39 degrees or higher. Again, indicating more severity of illness, and other signs of sepsis or septic shock. And in that, I would be including things like fever, as you've put there, and potentially a headache as well. Now, with the headache response, I again would probably specify severe headache, as you know, this from the history alone sounding very much like a sinusitis type presentation, and so we want to be specifying that if we're thinking a serious cause, we should be looking at severe headache. So very well done there. All right, let's go on for another question then. If you are ready, we'll get another 2 minutes on the clock, and your time starts now. Thankfully, she has none of those features, but did experience a fever of 38 degrees for a day or two when symptoms began, resolving quickly. Regardless, she's keen to speed up her recovery, as she's finding her symptoms frustrating while working. What management options are appropriate for her presentation? List 4 management options. Dosing is not required. right, so let's have a look at some of the answers. Again, I want to point out here that something that's relatively new in the scheme of these exams, and that is the fact that they are specifying that dosing is not required. So we presume, unless specifically requested, dosing will not be an element of the KFP exams. And there's been some hints from discussions with educators and the authors of the exam papers that it is very unlikely that any dosing will be required at all. Certainly if you've done some of the practice exams already, you will have noticed that is the case. And again, something you'll probably see time and time again is, of course, this line up here, that COVID has definitely been excluded. For some reason, they really want to emphasise that these exams aren't going to have anything to do with COVID, and I think that also reflects just the body of knowledge on COVID at the moment is probably evolving too rapidly for writing exam questions in a safe way around that topic for now. Of course, probably fair game in the future, so still something we want to keep on top of. So, answers and some excellent ones coming through. So, steam inhalation, paracetamol, pseudoephedrine, nasal spray, avoiding passive smoke exposure. Again, if I'm going to be super duper picky, the steam inhalation on its own isn't or wasn't listed in any of the marking rubrics I could find, and certainly in the checks and papers wasn't a part of it. Rather, things like saline irrigation, so your Fest sinus rinse or sinus sprays are recommended, not so much just direct steam inhalation, which doesn't have deeper penetration. But simple analgesia, spot on. Likewise, pseudoephedrine nasal spray for uncomplicated sinusitis isn't actually recommended at the moment. Instead, it's preferred to try things like intranasal corticosteroids or intranasal decongestants or ipratropium bromide in first instance. The ipratropium bromide as well, there's a bit of an atopic kind of component to it. Now, avoiding passive smoking exposure, absolutely nailed it. Again, going back to that information I gave in a STEM for free marks is acknowledging that the boyfriend does smoke and that smoke exposure is likely to exacerbate sinusitis. Now, some other answers put forward here would be oral antibiotics. Now, for uncomplicated, likely viral or atopic antibiotics are not recommended in first instance. If we were to say end up with a change, if symptoms worsened, if fevers had returned, if there was more of a purulent discharge from the nose, that or erythema or warmth over the sinuses, that would be, I think, when we're thinking more of that bacterial component, and then antibiotics would be indicated. But absolutely nailing it with saline nasal wash, nasal antihistamine spray, and boyfriend smoking cessation. Excellent. Of course, we can't say replace the boyfriend, but sometimes we're probably thinking it in the back of our head. Anyway, moving on. So I think the only one we haven't really talked about would be oral corticosteroids wouldn't be worth marks in this one, and antihistamines, which is an answer that often does pop up for these kinds of questions, doesn't actually have a lot of evidence behind it. And so while it is still common practice and probably not the best practice, there's no real evidence for efficacy behind it. And if we're trying to show that consultant level knowledge, you wouldn't be awarded the mark here. All right, so let's move along. We, of course, still have one more question to go. We'll pop 2 minutes on the clock, and your time starts now. So she makes a full recovery. She comes to see you 3 months later in tears, stating her boyfriend and her had broken up as she found out he was cheating on her with a mutual friend. She requests a sexually transmitted infection screen as she feels she doesn't know if she could have caught anything. Her and her boyfriend always use condoms and she is currently asymptomatic. You have no record of any previous investigations, and she states it has been years since she had any pathology other than her last CST performed 2 years ago. What screening would be appropriate to perform for Amelia? List 4 specific screening tests. right, so some great answers coming through. So for this kind of question, and this is a type of question that does come up fairly frequently in these exams, would be making sure that you've got a decent understanding of up-to-date STI guidelines. And for this, I would recommend using STI Guidelines Australia. So we've got a couple of answers that have come through here, and 100% correct in terms of urine chlamydia PCR, urine gonorrhea PCR, HIV serology is recommended for, and syphilis serology. They're 4 things that are recommended in all STI screens. Interestingly, we have specified that she is asymptomatic, and so in the guidelines currently, if you're asymptomatic, things like hepatitis C is not actually recommended as part of routine testing. So would be one that we wouldn't be having. Now, what would change that, for example, would be if she's living with HIV, if there's been any HIV pre-exposure prophylaxis use, any injecting drug use, anal sex with a partner with hepatitis C, incarceration, non-professional tattoos or body piercings, or receipt of organs or blood products before 1990. Now, I did have to read those off a prompt card that I'd made earlier because there's a rather set guideline there, but some things to keep in mind. Now, trichomonas would be screened in at-risk populations, but wouldn't be applicable without further information from this STEM. And things like screening for bacterial vaginosis is not recommended, or HPV is not recommended outside of any asymptomatic when you have otherwise recent cervical screening test. So we also have some awesome answers coming through. Well done, Samia. Absolutely nailed it, guys. You have done very well indeed.